So we should move to our next speaker. It's our guest from Russia, Professor Evgenya Sokolova, and he will speak about obesity in type 1 diabetes.
Dear colleagues, dear friends, it's a great pleasure for me to be here again and of course to discuss such an important topic as obesity. Especially I would like to talk about obesity in type 1 diabetes, which is a very important topic, and I will discuss why and what we can do here with all of you as clinicians. I will try to be more practical than scientific. And again, if you have any questions or you need any slides or some documents or links, you can just easily access me via email, which is written here. Don't be shy, just ask for presentation and I will send it to you. I will be more than happy because of that. As introduction, I just want to start with obvious fact. In the past 30 years, as you know, the prevalence of obesity has tripled worldwide to the extent that it is now being considered an epidemic. Of course, obesity defined as body mass index, more than 30 kilograms per meter quadrat, affects approximately 35% of men and 40% of women in United States. And obesity is rising at greater rates than overweight. Of course, there are some reasons for obesity epidemic, and sometimes it's not possible to find any healthy food around ourselves. That's the reason that the world now is looking like this. There are some pathways through which excess adiposity leads to major risk factor and for common chronic diseases, not only for diabetes, it's also complex diseases like atherosclerosis, Samson's liver, and so on and so forth. But also, type 1 diabetes percentage is increasing now, and it's true for all countries, not only for some of European countries. In other way, temporal pattern in overweight and obesity in type 1 diabetes is also increasing. And year by year, it's increased more and more. Type 1 diabetes patients have traditionally been thought to have lower BMI. Is it true? But for nowadays, it's understandable that there are so many obese patients with type 1 diabetes also in our countries. And also there are some connections between weight, type 1 diabetes duration, and currently the truth is that around 50% of patients with type 1 diabetes are either overweight or obese with higher waist, hip circumferences when compared to healthy control. That's why our patients with type 1 diabetes have some components of metabolic syndrome. In summary, they are overweight or obese, they have low HDL level, elevated triglyceride level, they have hypertension, they are obese, with some problems with lipidemia or, of course, polycystic ovarian syndrome. All these things about hepatic steatosis is also true not only for type 2 diabetes, but also for type 1 diabetes in this case. And of course, muscle also increase some risks for cardiovascular disease and through pathological mechanism for type 1 diabetes patients. That's approved with DCT data for 3 risk parameters with BMI, systolic blood pressure, triglyceride, LDL cholesterol, and HDL cholesterol level. Why is that true? What is the reason for this increasing of weight for our patients with type 1 diabetes? Of course, it's not only about intensive insulin therapy, it's also because of eating disorders, it's also about obesogenic environment, about some psychosocial factors, and some other with extended screen time, sleep disturbances, and for female. Why insulin is so important here? Of course, because it's an anabolic hormone, and you know this. It's also inhibiting protein catabolism and other metabolic processes in which weight gain may also occur to the increase of lean body mass, and because of differences between exogenous insulin action and endogenous insulin action. That's why proportion of adult patients with major weight gain occurring QRNCT was so high, as you remember. And of course, it depends of intensity of insulin therapy, type of insulin therapy, and also true is the growth hormone and insulin-like growth factor 1 is also important. There are some data from DCT, from meta-analysis, and of course, when we correct our patient with glucosuria, diuresis, and catabolism, it also can increase weight of our patient with type 1 diabetes. There are some data about prevalence of detamir here with some privileges of this action, some data about glargine, and some data about concentration of insulin, which can help our patients here. But also we need to remember about growth hormone and everything around it in this population. All of us, of course, remember that type 1 diabetes is autoimmune disease, but the second important thing here, that there are some factors contributing to the development of type 1 diabetes from obesity point of view. As you know, this accelerated hypothesis tells us that chronic low-grade inflammation from adiposity, self-tolerance mechanism deficiency, and glucotoxicity insulin resistance can lead to type 1 diabetes more frequently than without obesity. That's why there are some positions which can influence the new classification of diabetes, and of course, here you can see some sort of schematic factors affecting the phenotype of diabetes subgroups. And for now, it's understandable from cluster point of view. There is a much more insulin-dependent or insulin-independent situation, diabetes clusters that can lead us to better understanding what's going on with our patients. And of course, why we need to remember it? You want to have a photo of this slide, okay? I can move it back. And why we need to remember about it? Because it can influence of the treatment of our patient. It can influence on precision of medicine, and it can influence on some sort of personalization of treatment for our patient, even with type 1 diabetes. If we were just looking from the Maria Redonda point of view and about new classification of types of diabetes, here you can see that insulin resistance can persist not only in type 2 diabetes, but also in obese patients with type 1 diabetes. Before we can call it double diabetes or whatever you want to call it, but it's more than just simple explanation with type 1 diabetes, type 2 diabetes, other types of diabetes, and gestational diabetes. If you just go on from another point of view, here we can find another types of diabetes, thyroid-induced diabetes, post-transplant diabetes. Of course, we need to remember about monogenic type 1 diabetes and type 1 diabetes. So there are so many forms, and of course, we as clinicians need to remember about it. But the main reason here is that we don't even need to remember about classification and importance of classifications and about forms of diabetes. We also need to remember how we used to treat our patient before and what should we do now for better understanding of all processes with our type 1 diabetes patients with obesity. That's why we need to remember that there are so many strategies because of types of diabetes. And of course, as we discussed yesterday, sometimes there are we can find easily some overlaps between type 1 diabetes and type 2 diabetes when we're talking about type 1 diabetic patients who are obese or overweight. And it's impossible to say that C-peptide level will answer us or just antibodies level will answer us what shall we do with that type of patients. So they're difficult patients, but with our clinical point of view, we need to remember that there are specialized population and we need to work in a special way. Of course, what we should remember also, what is the reason to be obese for our type 1 diabetes patients, it's not only insulin action, it's not only double diabetes situation, but it also some barriers to exercise and physical activity and healthy diet in our type 1 diabetes patients. They warn about fear of hypoglycemia, about loss of diabetes control, about lack of motivation, about access to care, about body image. That's the reason. There are so many publications now that saying us that our patients with type 1 diabetes are not as physical active as we want from them. And here is a meta-analysis from 35 trials with more than 4,000 patients with such a conclusion that such use with type 1 diabetes seem to be less active, more sedentary, and have low cardiorespiratory fitness levels than their healthy peers. And I think that's a role for us here. So we need to push our type 1 diabetes patient to physical activity and healthy diet more than we did before. Of course, here we need to remember about consequences of overlap at type 1 and obesity, because here is all components of metabolic syndrome, it's also PCOS, and so on and so forth. So we know the reasons, we know the situation with incidence of obesity, type 1 diabetes, but now we need to think something about weight management in type 1 diabetes. And of course, as Jay Scaler said us several years ago, there are, of course, some ideal therapeutic goals in type 1 diabetes. It's prevention of immune destruction, preservation of beta cell mass, replacement generation of beta cells, automated insulin delivery, of course. But also for us, it's important now that weight management will have a greater role now and in the future. First of all, again, I just want to remind you that the main situation here is necessity to remember about education of our patients. We cannot do anything without education for patients with type 1 diabetes, and especially at some age, because here you can see that from infancy to toddlers to preschoolers, the management priorities difference. And of course, we need to remember that here in old elementary school, in early adolescence, we have to remind our patients about weight because they are concerned about it, and we need to put our attention here. Also, patients with type 1 diabetes, is true even now that they are in need of insulin doses to control their weight, and of course it can lead to reduction of weight, but it's very dangerous, and the level of decay here can be very high. And what can we do here? We need to remember from educational point of view about patient-centered communication with respectful, memorable, and open mindset, because we need to remember that all people want to be healthy. It's also true for our type 1 diabetes patients, and there are still some barriers with psychological issues, literacy, numeracy, and of course we need to screen for it. I just want to put your attention here. Of course, we need to ask our patient during our consultation not only about glucose level, not only about HbA1c level, but also what do you think about your body weight? What do you do for it? What is the physical activity level? Because usually we are just concerned about glycemic control of such patient, but it's not enough for now. Of course, there are so many things that we need to remember about physical activity and nutrition, and there are so many recommendations here about healthy diet, and it's the same for type 1 diabetes patient and the usual population, with attention not only for carbohydrates counting, but also for fat consumption, for protein consumption, and for some fiber amount, because it can influence on the glycemic index. And also we need to remember about avoiding over-basalization, about appropriate insulin dosages, because we have a lot of patients who overdose their basal insulin all over the world. Which opportunities we have now from medication point of view? Of course, we can some data about metformin, but we need to remember that adding of metformin to insulin doesn't always improve glycemic control. There are some studies confirming the body mass index improving, body composition improving, some reducing of cardiovascular disease risk, but still it's not possible to use it for all type 1 diabetes patients. It's just discussable for overweight and obese patients. What about new drugs? I just put my attention to SGLT2 inhibitors more because there are less information about it in publication. There are some data from studies with type 1 diabetes, because yesterday it was a question about this class of drugs. With some decrease in weight, you can see here about a couple of, from 2 to 5 kilograms. There are a lot of data about severe benefits to type 2 diabetes population. Can we agree with the fact that they have the same benefits applying to type 1 diabetes because of different pathology and duration diabetes can differ? But of course, there are some challenges, and I think that we will have more results in future. At least we have real-world benefits from the data who supported the usage of such medication in type 1 diabetes. There are some data even about possibility to use these medications for patients using closed-loop therapy and with good results. So as conclusion here, I just want to say that of course for now it's off-label, and of course it's a high rate of DKA risk, But with educated patients, I think that the future is here. Sometimes we really can use it because there are some issues for overweight and obese patients. If you just go to another so-called new class of medication, GLP-1 receptor agonists, the P4 inhibitors, there are still a lot of unknown here, and some patients use it off-label, trying to lose their weight. Some of them are successful, but here we need to remember about side effects and about cost of this medication for our patients. What about bariatric surgery? Is it possible for type 1 diabetes patients? Of course, from the theoretical point of view, is possible, and we need to remember that there are some pathways through glucagon, hepatic glucose output decreasing, with working with ectopic fat, with lipoproteins, with peripheral fat tissue, with adiponectin level, leptin level, lipotoxicity, because it will increase insulin sensitivity, so it will be better for glycemic control, not only for fat distribution in our type 1 diabetes patients. There are some publications here, and also for the question, is it possible to use bariatric surgery for type 1 diabetes patients? Of course, it's possible, but the data saying, observational mean data saying us that we need to perform it only in high experienced class of clinic with high experienced surgeons, because it's impossible to have excellent glucose control during the operation and after it, which is very important. So to conclude, I just want to tell you that prevalence of obesity has increased at faster rate in patients with type 1 diabetes than in general population. Of course, intensive insulin therapy, lack of physical activity, and development of new diabetes forms explains some of the mechanism for weight gain in patients with type 1 diabetes. Still little is studied about effective intervention for weight management in this population, who were portrayed before as being lean, and this myth is usually performed all over the world. Dietary intervention, increased physical activity and exercise, adjustment of insulin therapy, adding other diabetes medications that positively impact body weight, or adding anti-obesity medication need to be suggested and discussed in research also. If medical weight management fails, bariatric surgery are valid method for weight management in patients with type 1 diabetes, but we still need more data about this. And of course, education is still the key for effective treatment of such patients. Thank you for your attention, and I will be happy to answer your questions here.